You just need to toughen up, Marty.
I like that. I like that. I hope I'm recording. I want to save that and put that in the file of this.
All right. Good morning and welcome to Friday Chalk Talk, everyone. My name is Vonnie Coates. I'm one of the palliative care physicians here at St. Luke's in Milwaukee, and I'll be your moderator for today. Here at Luke's, we are lucky to have pharmacy residents rotate with us from time to time. Right now we have Kathleen Birch rotating with us, and she is a second-year oncology pharmacy resident. She will be giving a talk today on cannabis, a burning question in palliative care. I think this will be a great discussion, especially as our audience spans several states with different laws and regulations surrounding this. So I'm looking forward to it. And she will be giving a PowerPoint with some participation throughout the talk, and then an open discussion at the end. So Kathleen, I'll turn it over to you.
Great, thank you so much, Dr. Coates, for that introduction. And we can begin. So today we're going to be talking about medical cannabis use, especially in the palliative care population. And in this setting, there's really not great data, especially with medical cannabis at all, let alone in the palliative care population. So I thought that this would be a great way to kind of talk a little bit about it, as well as have some good discussion about the use of medical cannabis and cannabinoids, and then go through a little bit of the current literature that is out there. So when I started researching some about medical cannabis, I looked into a survey of Washington state providers. They surveyed 500 palliative care and hospice providers in 2015. So it was just a few years after they started using medical cannabis in Washington state. And with that, they found that 74% of the providers said that they think that medical cannabis would help with chronic debilitating conditions. However, only 21% of them have ever prescribed medical cannabis for their patients. So this discordance is definitely having to do with the state and federal legal statuses being different, and as well as a general lack of knowledge on how to handle medical cannabis in this setting. I thought that this was a nice map of the United States that shows kind of how each state is different with their laws and regulations regarding the use of recreational and medical cannabis. And at the federal level, medical or marijuana just remains as a Schedule I substance under the Controlled Substances Act. So essentially under the federal law, it is considered to have a high potential for dependency and no accepted medical use. However, all different state laws have different rules and regulations. So for Wisconsin, we have a CBD and low THC program. So what that means is that under a physician recommended use for any medical condition, the possession of cannabidiol in a form that does not have a psychoactive effect can be utilized. And this is under our Senate Bill 10. And then I think that this is a great map as well, just to see kind of the surrounding states and their different laws and regulations. I now wanted to open up just for a first initial audience question about what your thoughts or preconceived notions are about the use of medical cannabis. You can feel free to unmute yourself, or you can write any comments into the chat.
So we have a question. What disease is there? Oh, it's going a little fast here. What disease is there actual evidence to support it? I don't know if that's something you'll be covering, Kathleen.
Yes, we will be discussing that in a little bit, so that will be good.
Another question, I'm open to it. As you know, it would be good if we had more data. Worried it will open a can of worms where everyone feels that they need it. We have a lot of comments coming in. Can be very useful, probably underused. Some who have said that they've never prescribed it. Is there guidance for titration surrounding opioid changes? How often are folks recommending over-the-counter options for pain? Wondering how it's regulated.
And thank you everyone for your comments. I think those were really great to open up the conversation and discussion while we'll go through. So I will continue on. And the outline today that I have are to go through some of the different types of cannabinoids that are used today, as well as some recent literature. And then again, going back to an open discussion about the current challenges that providers face when patients may come in and want to use medical cannabis, and maybe providers are a little unsure or not wanting to use them. So there are two main types of cannabinoids that can be used. Phytocannabinoids are derived from the cannabis plant or hemp plant, and it is a derived oil resin. The one formulation is cannabidiol or CBD, which does not have any psychoactive components. And then delta-9 tetrahydrocannabidiol or THC is the component of the phytocannabinoids that does contain that psychoactive effect. There are also synthetic cannabinoids, such as dronabinol and nabilone, and these are analogs of phytocannabinoids that are manufactured in laboratories. So dronabinol is a synthetic THC, whereas nabilone has a combination of CBD and THC. There is also something else that we'll kind of discuss about in the current literature, but another formulation is called nabiximols, and that is currently not FDA approved in the United States. So we do not have that formulation in the US, but other countries are using nabiximols. And that is another similar formulation like nabilone with a CBD THC component, and it is an oral spray. So there are many different receptors that the cannabinoids can target in the body, and therefore it can affect many different areas of the body, such as the central nervous system, cardiovascular and gastrointestinal tract, as well as the immune system. And it can cause a lot of different effects in the body, whether those be positive or negative effects. And for some patients, maybe it is a positive effect, whereas others, it could be classified more as a negative or adverse effect. So with the cardiovascular system, euphoria is an effect that is seen in a lot of THC analogs and not as much in CBD. And this can be classified as a negative effect of the THC, but for some patients, they may enjoy the experience of that kind of euphoric rush when they are using cannabis. And then it can also reduce anxiety and any muscle spasticities, as well as have that analgesic effect and pain relief. With the cardiovascular system, hypotension is commonly seen. However, some patients can also form arrhythmias. So another thing to keep in mind with certain patients that they may have some sort of negative cardiovascular effects. With the GI effects, you can see some decreased satiety as well as decrease in GI motility. A lot of times people think that this can help with appetite stimulation and also can help with some nausea and vomiting effects in certain patients. However, with that decreased GI motility, some patients could experience more nausea and vomiting with that effect. And then with the immune system, immunosuppression can also be seen in some patients. And I did see some articles out there talking about how you can use medical cannabis for graft versus host disease in some patients. So I thought that that was pretty interesting in the allogeneic stem cell transplant population. I'm not sure how readily that's going to be used in the future, but there is a few articles about it, as well as anti-inflammatory effects that can help again with that pain relief. Going into the routes of administration, there are 4 main routes for cannabinoids. The first being kind of the most common that you think of, the inhalation route. It has a very quick onset of seconds, so that's why some patients may benefit from having that inhaled route, and you have that quick pain relief and quick feeling of kind of relieving those certain pains or nausea that they're experiencing right away. However, it has a shorter duration of action. With the sublingual and buccal formulations, it has still a short onset of action of 5 to 15 minutes. However, sometimes when you're putting something maybe under the tongue for it to get absorbed into the body, you may have some patients accidentally swallowing some of those oils that you're putting underneath the tongue. So therefore, it kind of has a variable duration of action where it could be anywhere from 4 to about 12 hours if patients are ingesting it more orally. For oral formulations, it has an onset of action of 1 hour, which still seems pretty quick, but if patients are used to doing the inhaled route, they may feel like the ingestible formulations aren't working for them, so they may start eating more. And then after a while, once it finally takes effect, they may experience some more of those psychoactive effects. So something also to keep in mind when talking to patients if this may be a route of formulation for them. And then finally, the transcutaneous topicals and creams and oils that patients can put on certain areas of the body that are experiencing pain, and they can get pain relief quickly in that area. There's no great data regarding the onset of action or duration for the topical formulations. So cannabinoids are metabolized through the liver. And an interesting thing about THC is that it does form some active metabolites when getting metabolized. And those active metabolites that it forms can be twice as potent as THC alone, and therefore can also kind of increase that psychoactive component that patients may experience. And then they both form inactive metabolites in the body before getting eliminated. It does go through the cytochrome P450 system when it gets metabolized. So there are some drug interactions to be aware of. Again, there's not great data as to if these are certain drug interactions that we should be concerned about when patients are taking them. But when patients are on CYP inhibitors, it can increase the serum concentration of the cannabinoids in the body, so it may enhance the effect. Whereas CYP inducers can decrease the concentration of the cannabinoids in the body, resulting in a less severe effect. So something to keep in mind, but again, it's not great data to support whether if a patient is taking rifampin, if you should kind of increase their concentration of their cannabis. So next I want to go into the literature. And again, I want to caution you with all of the data that I'll show on the next following slides, in that there's really variations in the sample size, the duration of the studies. Some studies are 2 weeks long, where others are multiple months long. And again, they use many different types of cannabis. So just things to keep in mind that there's limited medical research, especially for symptom management in kind of the advanced age and in patients that have serious illnesses. With the current literature, they're typically using cannabinoids to treat these 5 categories: pain, nausea, vomiting, depression and anxiety, as well as appetite stimulation if patients have cachexia. And then in the palliative care population, typically patients are either have cancer, have HIV or AIDS, and then have Alzheimer's disease. So the first 2 trials regarding pain are having to deal with cancer-related pain. And the first trial showed no significant pain relief and higher side effects compared to using it with placebo. The second trial had lower quality evidence, but patients did have significant pain relief compared to placebo and also receiving any other medications for their pain. And I also think it's interesting with the pain relieving trials that the side effects, sometimes they experience significant side effects, whereas other trials didn't even mention any side effects. And I think this is also something interesting in the fact that if some patients have chronic pain, they really want to be relieving of that pain. And so if we relieve the pain, they may think that these adverse effects that they're receiving aren't as bad as that severe pain that they are receiving. So I thought that that is kind of an interesting thought process with the pain articles that I was reading. The bottom 2 are systematic reviews and meta-analyses for patients that have chronic pain. And as you can see, there are a significant number of different types of cannabinoids that were used in these reviews, and some even had patients doing the inhaled cannabis options. And the third article that's on there showed significant benefit in patients receiving 30 to 50% of pain reduction compared to placebo. And then the second article, or the last article on the list, is also talking about how there's a moderate quality of evidence with pain reduction compared to placebo. So I think that that was some good articles that kind of related to a lot of different types of cannabis, but again, it's hard to extrapolate the data between the different types. These next two articles are nausea and vomiting related to chemotherapy. The top trial showed that there was significant benefits compared to placebo, as well as comparator drugs. And the most common drugs that I saw that them comparing it to was compazine, ondansetron, as well as metoclopramide. And then the bottom trial showed that there was no significant difference compared to placebo. So again, there's just a lot of varying data in regards to nausea and vomiting. These next two trials assessed appetite stimulations in patients that had cachexia with HIV and AIDS, as well as with patients that had cancer, to see if dronabinol can help with appetite stimulation. The first trial was a systematic review of 4 trials, and it showed that dronabinol was more effective in stimulating appetite compared to placebo. However, it was not as effective when compared to magestrol. The bottom trial was a randomized control trial of cancer patients that had a low quality of evidence, showing that there were no significant changes compared to placebo related to the caloric intake of those patients. So they weren't seeing that patients were eating any more, but they didn't really talk about if the patients were feeling any better, or maybe their appetite was increasing, but maybe they still weren't eating any more than they used to be, but they felt a little bit better. And then this last trial was a randomized control trial. It was double-blind and a crossover trial for patients that had agitation with Alzheimer's disease. I thought it was interesting that the mean age of these patients were 87 years old, so quite elderly, and there were 39 patients that were reviewed. They were looking to see if nabilone could help with that agitation, and there was some low quality evidence that there were significant improvements in agitation as well as in caregiver distress compared to placebo. The only downfall or side effect that was seen with the times that the patients were taking the nabilone was that they had increased sedation, which also could be a benefit in these patients if kind of the opposite would be to have severe agitation. They may prefer having a little bit more sedation in those patients. So to conclude all the current literature, overall more research is needed to find some statistically significant data in this setting, which would mean larger trials, longer durations, and again, having kind of the similar types of strains and all of those issues that we were seeing with the current trials that we had. This may never be reached in the palliative care setting, since at this point, this might be a last option that patients are on, and they may not be on it for quite a long time. And it's harder to get data in that patient population, especially with medical cannabis. So now I want to switch gears into more of a discussion for the remainder of our time. I have these 4 questions listed on the screen, and I'll read them aloud in a minute. But please feel free to either unmute yourself or again, write any comments you have in the chat. If any of these questions spark your interest, or if you have any other questions or discussion points that you want to talk about today.
Hi, this is Peter. I'm a pharmacist in oncology. I've done a little bit of research on this. I'm at Advocate Aurora Healthcare. I think the biggest thing that comes back to is all the research is done on different potencies, different strains of the cannabis plant. There are so many active compounds that are available that you look at one study and they might have used a different compound or a different amount of THC, a different amount of cannabidiol in the compound. So without that regulation, that standardization, you really cannot say for certain, even when you send, I've talked with other colleagues of mine in other states, when they send patients to dispensaries, they basically leave it up to the dispensary to decide what product would be best for that patient. They trust their expertise. So it's very interesting because when they prescribe it, it's not a particular anything. It's just the dispensary can give them whatever they want. Basically, there's no regulation. So with this kind of unregulated area, when we're used to having drugs regulated and you know exactly the number of milligrams of active drug you're actually giving a patient, a lot of questions will just continue to fly, and it'll just be very difficult to get strong evidence in any study that would be could be used across a large patient population.
Thank you, Peter, for those comments. I definitely agree with that. With the research that I was doing, there's really no great data or evidence. And even with the evidence that we do have, it's so variable with the different types of products that were used in each study. And then they are comparing different strains and different kind of combinations to each other, which may not be the highest quality of evidence as well.
Hi, this is Chandra. I think I've had two challenges where it comes to patients who want to use them. So one is more provider directed. When patients come in and they've been successful in using them at home, and then there's no real plan or mechanism for how to manage that inpatient, you know. And so that's been very difficult for patients who, you know, are less symptomatic for certain things when they're at home because they have access to their meds. And then when they come in, they can't. And then the second part is, I guess, is still provider related in the sense that soon as they start asking, you know, for a patient who's never been on them or they want more information, sometimes they feel like they're being met with, I don't even know what's the best word to use, but they don't quite feel comfortable asking, or once they've asked, they feel like they've been made to feel bad for asking, as if they're, you know, using it for, you know, like drug seeking type situation. So I don't know if there's something we can do as providers to help the patients feel more comfortable asking, but I also think that some of us as providers just don't have enough information and don't know what to say, so they just avoid the conversation.
Yeah, I feel like that's a very hard situation to be in as a provider as well as a patient. I feel like that makes a lot of sense with patients coming in and feeling uncomfortable asking the question itself, and then also feeling as if they do ask those questions that they would be judged by providers by even, you know, wanting to use those certain agents as a pain relief. I think definitely there's not great data out there to support or be against. And I think, you know, making your own kind of thoughts about the situation and making sure that when patients are approaching for those different situations, just being kind of upfront and honest with the patient on maybe your own thoughts and beliefs, and just making sure that patients feel that, you know, they have a comfortable space and place to discuss those issues with providers.
We have some more comments and questions. One provider said, we have provided dronabinol for inpatients if nausea is the biggest issue for a time-limited trial. One of our questions is, did any of your research address the cyclic vomiting syndromes that often occur with chronic cannabis use, especially if we are considering recommendations for treatment of nausea vomiting?
I did not specifically look into the hyperemesis syndromes with cannabis use for this topic discussion, but that is another thing to keep in mind, and more research as it's coming out on those different syndromes would be another beneficial thing to discuss to make sure that, you know, it raises awareness to everyone.
Has anybody out there listening ever had a string of really positive experiences using any of this? I feel like it's always a Hail Mary pass at the end. And sometimes I'm using it for the intended side effects, which I tend to not see anyways. I'm just curious if there's anybody out there that has some positive stories or some success stories to share.
This is Wendy Peltier. I would just add, and it's not completely parallel to the general palliative needs, but I'm a neurologist by background, and there is a lot of growing evidence about the benefit of cannabinoids for a number of neurologic conditions, very evidence-based. So there's some really, really rare forms of epilepsy in children where this has been helpful, and there's been legislation in Wisconsin about making those drugs available. And then if you're ever caring for someone with a disabling neurologic condition with spasticity, these drugs are actually very, very helpful for folks with spasticity who often don't have other options, and many times are dealing with a trade-off between being awake and uncomfortable or taking these, these medicines unconventionally, I guess I would say.
We have had a couple of patients in outpatient palliative care clinic that have been using medical marijuana for some time. We've had a couple that have been able to decrease opioids by about 50%. Through this, we've had probably 4 to 6 who've been able to decrease nausea while in the midst of cancer treatment. But there's a lot more patient enthusiasm beyond what we've seen as the efficacy with this. We're also very careful to monitor with every check-in about what are they using for marijuana use, where are they getting it from, how are they using it, how often, and what we're also finding is cost is a factor in people's adherence to continuance with this. So variability in its effects are sometimes evidenced by how frequently or infrequently they're able to continue with this. So it takes more provider inquiry to continue, but it is supportive for some people.
I don't know how many of us take care of pediatric patients. There's a comment that they've had someone with Lennox-Gastaut syndrome who finally got relief from continuous seizures. Any other questions?
I might go ahead and address my question. I put it in the chat, but okay. You addressed briefly studies on agitation in palliative care patients. I just ask whether there are comparative data to what I would call our traditional tools for trying to manage agitation.
The trials that I did see were compared to placebo, so with no other comparative medications being used for agitation specifically in those patients. So everything was really compared to a placebo and not any other types of medications.
This is Rachel. I put a file in the chat from Dr. McNett's chronic pain program. It was created in 2017, so it's a little outdated now. But when patients would ask us about CBD, that was his recommendation for education that we would provide for them. It's kind of more focused for Wisconsin residents, as it kind of talks about the Wisconsin laws, but it does provide some very basic information. So if that's useful, go ahead and find it in the chat.
Thank you, Rachel. Well, then I think we'll wrap up for today. Thank you for the discussion, everyone. It seems like we've had a wide array of experiences.
Thank you, everyone.
Yeah.
Thanks.